Okay, well, welcome everybody to the second installment of the Australian Healthcare Index. We are talking today with a group of esteemed people from across the healthcare sector. My name is Dr. Marcus Tan. I'm the CEO and founder of Healthengine. Healthengine is Australia's largest consumer online healthcare platform. And we're here to help patients navigate the complex world of healthcare, making their journeys more affordable, convenient, and certain. I'm joined by Stephen Mason, who is the CEO and partner for the Australian Healthcare Index with Healthengine of the Australian Patients Association. I'm also joined by Seth Ginsberg, who's the co-founder and chairman of the Global Healthy Living Foundation, and Dr. Rachel David, who's the CEO of Private Healthcare Australia. Online, we also have a bunch of participants across the industry from the provider sector, private health insurance, the pharma sector, and quite a few not-for-profits and government. So welcome. I firstly wanted to talk to you a little bit about the Australian Healthcare Index. And for those of you who aren't familiar with it, it is the second installment of it. It is a 6-monthly report that the Australian Patient Association Healthengine have commissioned. It surveys around about 4,000 Australians from across the nation with a good representation across different demographic groups. And basically it's around about consumer experience of the healthcare sector, and really to try and give a little bit of a report card to give a sense as to how the sector is actually performing for the consumer. And so what I'd like to do is really just kick off this fireside chat with the key findings of this report. But before we do that, I'd like to be able to give, firstly, Stephen, maybe the opportunity just to say a little bit about yourself and the organisation and the Australian Patients Association, and then maybe Seth and Rachel after that. Steve?
Thanks very much, Marcus. The Australian Patients Association is a peak body in Australia to support patients. We not only support patients, we advocate on their behalf, and we inform and educate them. So we're delighted to participate with Healthengine in this Australian Healthcare Index report. This is a vital survey, and as you know, we've surveyed the whole of Australian and all cohorts. So it's a very beneficial report.
Thanks, Stephen. And Seth?
Yes, g'day. My name's Seth Ginsberg. I'm the co-founder and president of the Global Healthy Living Foundation. We're a 22-year-old patient advocacy organization with the mission to improve access to care for people with chronic diseases. Originally founded in New York, in the US, where I was born. In fact, just with your indulgence, I want to note I was born about 10 minutes ago, 40 years ago. 40 years ago this hour, right now in New York, technically. But 40 years later, I find myself in northern New South Wales, talking to you about health advocacy. And it's been a lifetime passion of mine to represent people with chronic diseases. And we find ourselves here in interesting times as a global community of patients. And I just want to thank you for the invitation to participate in today's discussion, and I'm delighted to be a part of it.
Thanks, Seth, and happy birthday by the sounds. Despite the name being slightly different, Rachel, would you like to give a quick introduction of yourself and private healthcare?
Yes, hi everyone. I'm Dr. Rachel David. I'm the CEO of Private Healthcare Australia. We're an organisation that represents private health funds here in Australia. We represent 98% of the health insurance industry based on membership. Delighted to be here today with my colleague Stephen in particular, with whom we've had a really interesting dialogue about this survey. You know, our members are the most important thing to us. They are our number one priority when we negotiate with governments and other providers in the health sector. And so the data that we get from surveys like these is critically important as we look at some of the big issues around healthcare access, costs, and quality in particular.
Great, thanks so much, Rachel. So before we kick off, I'd like to just quickly mention that if you are interested in the Healthcare Index and you haven't seen it yet, the report is actually available on our website, which is australianhealthcareindex.com.au. feel free to download it from there. There'll also be the webinar that we are recording right now, and that'll be posted on there as well for future reference if you are interested. So what I'll do is, before we kick off the discussion, maybe just give you a framing of some of the key findings so that we can get a sense as to the sort of areas that people are interested in. And I think as part of an index, we do try to rate the healthcare system as difficult as that may be, because it's quite a diverse sector, and obviously different issues will emerge over time. But we have been trying to sort of work out, well, look, what are things that consumers care about? How will they actually determine whether the healthcare for them is being met in a way that they feel is good and get some good outcomes and experiences? The rating has, for this time around, come back as 7.6 for the Australian healthcare system. And that's actually largely in line with what we had last report about 6 months ago. So that's probably a good thing, considering some of the healthcare challenges that people have been facing, particularly associated with COVID. Interestingly, the top 3 issues this time around have been around the sort of private health insurance costs, around COVID vaccination programs, and the wait times associated with emergency departments. And sort of rounding out the sort of top 5 was issues around mental health access, and also the issues around elective surgery. So I think what we'll do is we'll try and cover off the top 3 at the very least. I do invite people who are online to actually submit some questions through to the Q&A and chat function that is in the bottom of your screen there. And we'll continue to monitor that, and hopefully we'll be able to get to any questions that are posted. But what I'll do is I'll start with COVID, which is obviously the thing that's on everybody's minds at the moment. And maybe start with Seth. You've obviously got a science background. You're very familiar with some of the issues being faced out in the community by people, particularly of with chronic diseases and other illnesses. And I'm kind of interested to get your take on some of the findings here. So what we've actually found, and certainly at the time of our survey, which is several months ago now, but probably in line with the momentum of the vaccine rollout, is that about 50% of, at the time, had been at least given 1 dose of the COVID vaccine, and the other 50% obviously hadn't. Now, one of the interesting findings of that, when asked around why they hadn't received the first jab, it appeared that a reasonably small fraction had said that, about 7% had said that they didn't want to be vaccinated at all. 17% had said that they were undecided about it. 34% said that they were waiting for a different vaccine to be available. And fortunately, the big number of 42% being not eligible probably doesn't quite apply anymore. But interestingly, a big chunk of the people who said that they weren't interested in being vaccinated or undecided had said that they weren't interested because they didn't think that the vaccine was safe. The other secondary reason was that they felt that the vaccine had side effects that they were really unpalatable and were afraid of. Seth, do you want to comment on that, and sort of any thoughts on safety of vaccines and this is the general community view on vaccines?
Yeah, and I'll do so very delicately, and I should qualify my response, and actually pre-qualify that by saying how awesome this report is in the index, and how interesting I found all the findings kind of at a larger level. Obviously honing into the COVID section, which had a really great cross section of different perspectives from patients living with chronic diseases. I took with great interest because we represent these folks, and this has been the single most treacherous year and a half for everybody technically, but for especially most vulnerable people with chronic conditions. And what a pandemic does, a worldwide pandemic does, is it really brings public health to the front of mind, and it manifests in every way within our lives. And it does it, or it did in this case, very abruptly, I think we've realized. And so I think the 1 year I've spent here in Australia, I've had the opportunity to see a roller coaster, is the best word I can think of, for how this country has been going through the last 12 months that I've been on the ground here of COVID, and certainly with 6 or 8 months predating that. And so what it brings us to the conclusion of, basically, and I think the important takeaway for us is the necessity of vaccines. and the requirement for societies in general, Australia, but everywhere else as well, to embrace vaccines as truly the way out of this. And Australia knows that. Australian patients know that. Other developed and developing countries know that. But I think we're at a particularly vulnerable time in life. We're in a particularly vulnerable place, beginning as people with chronic diseases, but as communities and societies writ large. And I appreciate the appreciation for vaccinations that the chronic disease patients have brought into this conversation, but now for whom it matters most and for whom the emphasis rightly belongs. And that's why, again, I want to commend the Australian Patients Association, and I really super dig what you're doing with Healthengine, and putting this healthcare index together for Australia is a really valuable snapshot for all stakeholders who are hopefully playing a role in this case, getting us out of a pandemic.
Yeah, thanks, Seth. And I guess, just building on that, do you feel, there was a section in the index that actually asked about people's views on vaccinating children with COVID vaccines. And sort of actually, pleasingly, there was a resounding majority that, that said, look, they were quite happy for children to be vaccinated, and they were in favor of that. Only 12% said, look, no, they weren't in favor of children being vaccinated. Obviously children also have, increasingly got, congenital and longer term chronic type of diseases. Is this the sort of thing that, does your advice change around the safety of vaccines and other things for children, particularly in that sort of vulnerable age, vulnerable group?
When it comes to children, I have two beautiful ones of my own, young ones. All I can say is, we double down on the advice of the regulators, of ATAGI in this case, of FDA, and we look to them to ensure our children, just as they have children, are safe and protected. And that's what vaccines have done for now our generations of families who have not had to come even close to measles or a litany of other horrific diseases that these poor kids perished with before us. And so it's more important than ever when it comes to children, but I think we should put a pin in this October 12th here, October 12th, on our discussion of children, because unfortunately, I fear for what is impending with Australia in the near future. And I'm just kind of bracing for us to embrace vaccines for children as quickly as possible. But now I'm out of my I don't want to speak to regulations. I'm just speaking as a father to ensure proper protection for all.
Yeah, thanks. And I'll throw it maybe to Rachel or to Stephen. How's the COVID side of things impacted either the private health insurance sector or sort of patients more broadly from your experience?
Sure. Well, look, I do concur with some of Seth's comments. I had a huge sigh of relief today when my youngest two children got their second dose of the vaccines. I spent a long time working for Pfizer, then Wyeth, and then CSL here in Australia, advocating for vaccines. So I'm incredibly proud that, and I feel very lucky that we're able to be in a country where they're so widely available. And it certainly will be, we wouldn't want to be living in any other time. Looking back at what happened in the 1919 pandemic, for example, by way of contrast. In terms of how our sector has been affected, yes, we have had a few quite spectacular claims come through for people who have been admitted to hospital and gone to ICU with COVID-19, but the main impact has been on the widespread cancellation of public elective surgery and the incredible volatility of in access to private specialists that has occurred as a result of the lockdowns. What the effect is that there've been periods where people haven't been able to get surgery, but they've rebounded back very fast when the lockdowns have been released. So that's been quite challenging to manage in terms of managing claims. But perhaps the biggest impact on consumers, which we're really seeing across the board in all states, is the lack of ability to access elective surgery in the public sector and the lack of ability to be able to access inpatient mental health care in the public sector has meant that we've had a lot of people feeling they need to join private health insurance or stay in private health insurance, and therefore budget for some quite significant premium costs. And that then puts the onus on us and our federal regulators to do everything we can to manage those costs so that access to these essential services can be maintained, because there are whole regions in Australia where they are just not available in the public sector at the moment and won't be for some time.
Yeah, it's actually in line with some of the numbers that we're actually seeing out of the report. I was actually going to touch on this later, but I think now that you've raised it, I think it's a pretty important topic that maybe is worthwhile just segueing into just temporarily. We obviously had a section of talking about elective surgery, and obviously a lot of elective surgery is done in the public sector as well as in the private sector. Of the survey, we actually did find that there were quite a few people on the public hospital waiting lists, for instance, that had actually blown out outside of the categories that they were meant to be seen for. So to give you an example, the category ones where you're technically needing to have been seen or had treatment within 30 days. People, were saying that and there was a reasonable chunk of people in that segment. People were saying that around about half were sitting outside of that 30-day window that they were supposed to be seen, and that's pretty worrying, obviously, because obviously these are things like cancer treatments and so on that have a certain level of urgency. Similar sort of numbers, in fact, much the same in category 2s, which are needing some treatment within 90 days, around about 50% outside of that waiting, that sort of window of treatment that they were supposedly seen for. So obviously, these sorts of cancellations and restrictions that occur largely because of COVID have had knock-on effects, and people who are supposed to be being seen aren't being seen, and so I think it's a relevant conversation. Stephen, do you have any thoughts on again COVID impacts, and particularly in relation to things like elective surgery and so on?
I do. The Australian Patients Association has been working closely with Seth and the Global Healthy Living Foundation on combating vaccine hesitancy. It's been a major problem, and it was hard to relate to minority groups, a lot of ethnic groups, and there were too many minority groups were fed misinformation. So misinformation has been a major challenge, particularly those who don't address the mainstream media and rely on Facebook and social media. There's a lot of misinformation, which has been a challenge to combat. But we are having some success. Interesting, recently we've found that there's a high percentage of people that just are frightened of needles. They didn't like to give the reason why they weren't getting vaccinated, but a survey that was conducted said that 65% of people don't like needles, but there's a small cohort that got needle phobia. They won't go anywhere near a needle, so they make all the excuses in the world to avoid going to the GP or to a bulk vaccination clinic to get treated. So that's another issue we've got to overcome. But Rachel touched on the issue of elective surgery. That's the number one complaint we get as an association, people contacting us concerned about elective surgery. Now, major concern at present is those surgeries that at the time weren't life-threatening, they were category 2, should be done within 90 days, particularly with people with heart problems and cancer issues. They can wait 30 days, 60 days, but once they've waited 90 days, 100 days, etc., it can become life-threatening. And we're very concerned about that because the hospitals are under immense stress at present. They're having staff shortages. Certainly in Sydney and Melbourne, they've got all the COVID patients as well. So we've got to find solutions to that. I know Rachel's got a few solutions, but a lot of it will depend on utilising the private hospital system and the surgeons resources that they've got available.
Yeah, thanks, Stephen. Do you want to respond to that, Rachel? I mean, what are the things that the private health insurance sector are actually doing to try and encourage more elective surgery and maybe take some of the pressure off the public hospital system?
I'd love to. Thanks, Marcus. I just wanted to make the point also, in addition to what Stephen was saying, that even if you're category 3, in terms of the public wait times for elective surgery, this is not like cosmetic or non-essential surgery. We have people in category 3 who are in such severe pain they can't walk and who are going blind, sitting on those waiting lists. So, that means they can't drive their car, they can't go to work, they can't really do much other than, get off the couch. So, these are serious issues, and increasingly we're seeing people having to manage, some quite hefty premiums to, particularly if they're joining a health fund for the first time later in life, to be able to access surgery, and in some areas out-of-pocket costs as well. So how we're working to manage this with health funds is challenging, because a lot of the solutions rely on us getting regulatory change and persuading the federal government that they need to alter some of the regulations around private health. The big one has been for us the excessive benefits that we've had to pay out for medical, commonly used commoditized medical implants and equipment. This is regulated by the federal government, but the Australian prices for some of these things, like just basic sponges and suture tape, glues, are easily the highest in the world. And we've had to work really hard to persuade the government to re-regulate that area, and in some cases deregulate that area to bring those prices in line with market prices, so we can pass on a lower premium to consumers that are covered for surgery, because that's a really big driver of the cost of surgery in Australia. Paying 30 to 800% more for commonly used cheap items is not acceptable, and there's no clinical reason or supply chain reason for us to be paying an Australia tax for something that's so easily manufactured. The other thing that we're also working on a number of things to make private health more attractive to younger people. And the reason that younger people claim is predominantly due to the fact that private health covers the majority of inpatient mental health care in Australia. It's the number one reason why men under 35 claim, and actually no, why women under 35 claim, and the second highest reason why men under 35 claim. It's took over from reproductive health about 5 or 6 years ago as being a major cost of claims. So in terms of access to mental health, we've done 3 things. The federal government has introduced the ability for us to discount premiums for younger people. It's enabled health funds to offer products where younger people can be on their parents' policy until age 30. And it has also enabled people that are on a very basic level of cover, if they are unexpectedly admitted to a mental health facility, they can have a cover note issued on that day for a higher level cover without a waiting list, so that their full treatment is covered. And I think those things have really stabilised some of the issues that we've had with younger people. However, we still have a very big challenge with an ageing population in our community-rated health insurance system. There is still a significant cross-subsidy that goes between younger people and older people. And that's something that's going to take, some work to address. And whether that's through, some of the economic studies that the government have commissioned at the moment, or a bigger review, I don't know. But it's going to become a critical issue. The final point on that I'll make as well is that there's been for low and middle income earners, there is a rebate on premiums. that has been declining over the last few years because it's been capped at a particular level. It rises in line with CPI, not health insurance, not health system costs. We would like to see that re-indexed to healthcare costs for low-income earners, because again, predominantly for young people, that helps address some of those cost issues.
Yeah, I mean, we can talk a little bit about private health insurance costs shortly, Rachel. I think there's a lot there to unpick. I think interestingly, there's a bit of feedback coming through on the chat channels, and you know, to your point about maybe there's a bit of a vicious cycle happening around particularly elective surgery, where people who are even in category 3s, where they're waiting for things that might not be as urgent, but actually are still impacting them, and postponements really kind of not just have an emotional toll, but potentially, because they're struggling with pain, may not be working and so on, may actually be, you know, with that postponement actually impacting their financial well-being as well. I think there was a question maybe to Stephen or to Seth, really to talk about whether there was any other areas that that you were aware of that patients might be able to seek some sort of financial assistance or other things in these sorts of circumstances where maybe private health insurance and other things might not be able to assist.
I would defer to Stephen on that, specifically here in Australia.
Thanks, Seth. Look, I'm not really aware of any help. The Pharmacy Guild and ourselves and a couple of other parties actually requested the federal government to, you know, provide some assistance for people who got vaccinated, had adverse side effects and therefore couldn't work and had a financial loss. And in Britain and other countries, the government had agreed to such a scheme. They've agreed to compensate you know, doctors and pharmacists if there's any claims against them for providing the injection. But unfortunately, I'm not aware of any assistance for patients who you know, fall ill.
Yeah. Sorry, was there another comment there?
Sorry, I was just going to build on that though, and just, you know, make the point that we're all going through, again, like a really challenging situation, and we have to look at this in context, and we have to realize that like the whole game board has been completely shifted by COVID. Everything about healthcare is now just operating differently in so many ways, and the burden falls to the sickest and the illest and the people most vulnerable medically, and that cascades because it's never just one thing, and it's always something as well, and the mental health compounded, and we're going through tough times, and it's falling on the healthcare sector to keep societies going. And I believe in Australia, and I believe that this is a smart place with smart people that are taking stock of these impacts at so many levels, from the basic community to the local health, your local health group that you know, at the community level all the way at the federal and Commonwealth level, have really identified the challenges that everyone's going through in really dynamic ways. But this index, this healthcare index, is now again going to be like doubly important going forward, because things are still rapidly changing and the impacts are downstream compounded elsewhere, that the healthcare industry has to recognize that that it's changing rapidly and it's devolving in many areas, but things like vaccines are tending to save the day, thank God. But I think that when we put all this together, we realize that whatever used to be is not going to be in the future, for care delivery, for the way people like wake up and how they feel and what they think about and what they're going about doing is just different now. And that ripples through their various ailments, and it hits the healthcare system hard. But again, Australia is poised to be responsive, is a responsible country, and has a pretty direct line into the wants and needs of its population, which is really admirable. And I wish that of America. But these indexes, I just want to say one more time, are like really critical to keeping an eye on the ball, which is like changing directions very rapidly still.
Yeah, well, look, I think and thank you, Seth. I think that those are really good points. I think you've talked a lot about cascading, and I think really the next subject that I wanted to touch on, which is one of the key issues, was around emergency department waiting time. And I think that a lot of the discussion around, whether it's bed block and elective surgery, increased demand from COVID, sort of leads into the same sort of cascade and the interdependency of the whole healthcare system. And emergency departments can sometimes become that sort of pressure point. And I guess that maybe let's talk a little bit about that, because that's obviously a concern. Ambulance ramping is also another key feature of the report. It's something that patients often use as a marker of how healthy the system is how long they're waiting in emergency departments. Stephen, do you want to just talk a little bit about what you're seeing out, from patient feedback and other things around issues like ambulance ramping and so on?
Certainly. Apart from waiting lists for elective surgery, we get so many complaints about waiting times in emergency departments. And a critical concern is just the poor communication. The emergency department is just flooded and can't cope and basically imploding. Patients kept waiting inordinate amounts of time. There's no chairs to sit. The conditions are generally pretty poor. Nowadays, someone falls ill in an aged care facility, they just call an ambulance, ship them off to the nearest emergency department. The ambulances are not as productive as they used to be with COVID patients, because the ambulance has to go back and get thoroughly cleaned, and that takes a few hours. And we've seen all the problems with ambulance ramping. Instead of an ambulance driver and paramedic being able to attend to, say, 8 patients in a day, they're only seeing 2 or 3, and they're spending hours waiting at hospitals to discharge their patients. The trouble is, once they get inside, often the emergency departments are a bit chaotic. There's no communication at all. We get calls, messages every day. People have been waiting for 6 hours. And I particularly feel for young people that have got mental health issues, could be suicidal. They've been on Lifeline, Beyond Blue, waiting for a while, so they go to the emergency department and they're just kept there for 6 hours. 2 or 3 times they'll go up to reception and they don't get any response. When are they likely to be seen? A lot of them just go home in a very poor state and worse than when they arrive. But communication, long waiting times, poor facilities, even when they're discharged, often they don't get discharge notes. They feel there's a lack of care, and this is not to deride all the fantastic staff that are in these emergency departments. A lot of them have been just worked off their feet. They're trying to do their best, but when they're swamped. So we really need more funding for emergency department, more funding for hospitals in general, because they need more staff, more resources, and that requires more money.
Yeah, and I think interestingly from the survey, we saw that about, say, 24% of people who had completed the survey had said that they'd actually attended an emergency department in the last 6 months. Obviously, a large chunk of that is in public hospitals, but actually there are about 8% that actually visit private hospitals. Rachel, have you sort of started to see a trend towards private hospitals offering emergency department care as well? And how does the private health insurance sector potentially also contribute to alleviating some of these sorts of issues that you're seeing in the public sector?
Well, look, our role can be a little bit limited by the regulations that we operate under in Australia, because we're not permitted to co-fund and a medical service that occurs outside of hospital, so a not admitted medical service where an MBS benefit might be payable, and that includes private emergency and private GP visits in urgent care clinics. This does create a bit of a barrier to setting up these services, because where we do see them in some of the larger, and they tend to be in some of the larger private hospital groups and networks, the copays can be quite significant for someone who's on a low to average income. So we're talking about $400 or $500. Now that might be worth it if you've broken a limb and you're in excruciating pain and or something, you've had an accident and you want immediate care by a medical specialist. So what you tend to see in those services is a lot of sporting injuries and mental health. People that need have an exacerbation of an existing mental health condition. So what I think would be a potential solution, if particularly in some areas of need, where we could do it first, I'm not talking about like reframing the whole Medicare system, but I think if we were to focus on some areas of need, and the one that I'm thinking of at the moment is Northern Tasmania, where there is a serious problem with access to hospital type services, and you have the emergence of GP-led urgent care clinics to take the pressure off. We would love to be able to co-fund some of those and offer a zero co-payment option for consumers in those areas. It doesn't have to be across the board outside areas of need, but I think in some of those communities, the government, given the situation that we're in with COVID, just needs to take a pragmatic and non-philosophical decision about addressing some of these issues and working with health funds and permitting us to offer a no copay service.
Yeah, that's super interesting, Rachel. I think obviously the renegotiating the Australian Healthcare Agreement is going to be an interesting one. You've obviously you've got a background of having worked in the corridors of power on the other side in policy making. How do you feel about the likelihood of that actually happening, allowing private health insurers to actually work in with the sort of community sector and so on, and potentially offer up some option that will be for the copay? Does it have unintended consequences that obviously the agreement is there to try and prevent?
Look, I think the main unintended consequence that people raise with us is some kind of wholesale cost shifting activity, which puts a particular group of consumers at a disadvantage. But there are ways around that. And honestly, I think we are going to be we don't want to find ourselves at a situation of crisis of access to services because of some kind of prejudice or philosophical attitude that's not right for the times. And I think really we are going to have to think creatively and in a pragmatic way about how all of the funders in our health system can actually work together to meet consumers' needs, even if it means regulatory change in some areas, because we are seeing large, not everywhere, but we're seeing large sections of the community at the moment where under the Medicare system, they actually can't access the services that, some basic services. And that's in part, this was a trend that was occurring before COVID-19 because of workforce shortages and other inequities, but it's been made much worse by the pandemic and the shutdown of services.
Yeah, and I think that's a good segue to the private health insurance cost issue, because I think the survey, it seemed to be a little bit binary in the sense that, we had private health insurance, get a lot of kudos for the coverage that it provides, and yet, sort of also a lot of dissatisfaction around the cost and the value and affordability aspect of it. I will start with you, Rachel, but keen to sort of get Stephen and Seth into this conversation as well. I think the conversation that you've started around, and you mentioned this earlier around the sort of steps that private health insurance sector are looking to try and improve affordability. How do you feel like that's going? Do you feel that it's being reflected in terms of membership rates and what are you seeing in the sector around those issues around coverage and cost?
Well, look, we had a significant decline in membership up until 2019. Hospital cover had fallen to under 45%, but since the pandemic, it's actually picked up again. Including in younger people. And I think the reason for that is exactly what we've discussed. There are services that people can't access in the public sector at the moment, whether it's category 2 or 3 elective surgery or mental health care, they would be the big ones. So, but that it comes with a cost, and particularly the system that we have in Australia does make it quite expensive. There is a community rated system where we don't look at people's health status to determine the premium. So you could be, we could have 2 people aged 30. One could be involved in contact sports, be morbidly obese, a smoker and a drug taker. And the second could be doing none of those things, and they would both be paying the same premium because we don't risk rate it. So that does make it more expensive, because, particularly for younger people, because there's a cross subsidy in there that they fund the older generation. And in turn, as they get older, they're funded by a new generation of people coming through, which is fine. But when you've got an aging population, it starts to get very difficult to sustain. So that makes it more expensive. And then the regulations that we operate under, which essentially compel health funds to pay, which is very different from in the United States. We actually are bolted in to the Medicare system. We're not a separate system, but we're a second layer of the Medicare system, where if the Medicare system pays for something, the health funds have to pay for it as well in any hospital. So it's not as if we can sort of say, okay, well, we're only going to pay for certain things in certain hospitals. It doesn't work like that in Australia. So to keep costs down, we only have a few levers. And the first one is just the complete waste that's going on in the medical supplies and technology space. Everybody knows it's a problem, but it's been very hard to fix because, you know, people have been making a lot of money out of the system as it is, whether it's the device manufacturers, the multinationals, or even some providers that have been able to achieve quite high rebates against these regulated prices. It's been very difficult to fix. It will be fixed. The last federal budget showed the federal government was really on top of this as a lever to safely reduce premiums without restricting access to services. And I'm delighted to say that from February of next year, we will no longer be paying 8 times the price of a surgical sponge as anywhere else in the world. So, it's been a long time, but we will get this done, and it will be reflected in lower premiums than people otherwise would have paid. And then once we can get some of these things under control, the other one is obviously, getting the agencies, the Quality and Safety Commission, and other medical societies to work with clinicians on reducing some of the low value care in the system. And I think we've seen great success with the Quality and Safety Commission and the Australian Orthopaedic Association in eliminating unnecessary knee arthroscopies, which was a big cost and offered very little benefit to patients. And I think there are a few more things like that we can, the system can begin to work at moving on from. And once some of those runaway costs are under control, I think the final thing is there a level of subsidy? What's the right level of subsidy for the government to put in to sustain community rating? And that's all about the rebate on premiums and how it's targeted. And I think that's always been up for debate. It's quite a highly politicised issue. At the moment, I fully agree with means testing it. And I do think there needs to be a way of keeping the system affordable for younger people, and maybe looking at removing some of the constraints on the rebate for lower income earners, so it truly reflects the cost of healthcare is the way to do that.
Yeah, that's you've opened up some really interesting conversations there. Community rating, risk rating. These are all very contentious issues. I think from a patient perspective, the idea that maybe we move away from community rating into more of a risk rated, more of a typical life insurance type of environment where patients are potentially rated on their risk, and a lot of these are lifestyle related type of risks, obviously, as much as they are potentially just genetic ones. Like how do you feel on the patient side, either Seth or Stephen, about the potential introduction of something, or a change in the regulation around that to potentially move more to a risk-rated type of environment? What would be the impacts to patients on that?
Well, Marcus, we've commented on this before, and I know it's rather topical and it's a political issue, but we have suggested for those under 35, you should have the option of risk-rated, because a lot of young people feel that they're subsidising the older ones. And when you look closely at the survey, you'll notice that people over 65 were very happy with their private health insurance, and they thought they were getting excellent value for money and into some of the best private hospitals in Australia. The ones that were a bit disgruntled were really more the 30 to 50. We're subsidising the older ones. We've got mortgage stress. We've got private health fees. We've got other expenses. The older people, are retired. They're fully paid off their house. No children to look after. Health's number one, and they're getting great value for money for their private health insurance. Now, it's always been a challenge to get young people in their early 20s, early 30s into private health, because they're saying, I'm fit and healthy, I'm looking after myself. Why should I pay this premium? I've got public hospitals and emergency departments. If an emergency happens, a lot of sporting clubs have their own health insurance if there's an accident on the field. But I really think it's worth just looking at, for a certain age group, up to 35, having it risk-rated. So you've really got the two systems. But how many people at 18, 19, 20, 21 are taking up private health insurance? They don't really feel they need it. And with the new initiative where if you're struggling, you can be on your parents' private health insurance to 30. That's another good option for young people. But look, there are a lot of issues with private health insurance, but it's pleased to see Rachel and Private Healthcare Australia working on it. I know they've complained a lot about the cost of sponges and other devices. By world standards, we were paying the most expensive price in the world, which is ridiculous. But I know there's a few other issues to work through with medical devices, particularly heart-related, where a lot of heart patients need a specific device, and in their opinion, one size doesn't fit all. So would be good if we all got a black Ford, because it would bring down the cost. But there's some areas where you do need choice, and that has to be worked through. And I know it's not an easy topic.
And I'll just say, as an American, the words health insurance are pretty triggering. So, recognizing the vast differences in our situation, but now the perspective of having spent a year and actually shopping for private insurance, knowing that we intend to remain here for a little bit. So after my celebration of receiving my Medicare card, which as an American, again, I want to acknowledge, it's a good baseline system. We're talking about the enrichment of society in smart and fundamentally important ways when we enter a conversation about private health insurance in Australia. And that's super admirable. And in saying that, I think when, maybe looking at terms like risk rating and such, and including other terms like well care and, stimulating healthy living and healthy lifestyles and healthy behavior, I think Australia really has the opportunity to do that in this type of situation. And then also I'll say it's ironic in some ways that, the country, Australia as a market, pays so much for certain products. I think sponges have been referenced a few times today, but yet on a worldwide stage is one of the, has the lowest prices for things like drugs and medications and therapeutics. And so there's an interesting, situation with respect to that. But generally speaking, this is the opportunity for us to closely examine how to ensure healthy living, healthy outcomes, and positive health activities among the population. And I think that's the essence of what good insurance ought to be about when it comes to healthcare. So it's very encouraging overall.
Yeah, thanks, Seth, and thanks for some the people online who are actually submitting feedback and questions as well. I actually did have a piece of feedback that I thought was interesting, and this was that in response to the risk rating side of things, is that what happens to patients that have paid for private health insurance all their lives and are now unwell. That would certainly make risk rating totally unfair. I mean, obviously, whenever you pivot and change certain policies and other things, there are always some people who are on the edges that will actually be impacted because of some of those changes. Any thoughts on how you might be able to make some of those transitions without sort of having people fall through the cracks?
Marcus, with risk rating, I was only saying that applies to young people under 35.
That's right.
Once you're over 35, there's no risk rating.
Yeah. Rachel, you've got your hand up there. You're on mute, by the way. Yeah.
To make that work, it is actually quite complex. So you don't end up with premium volatility. And what it would mean is taking the funding that we have for the rebate, which is roughly just over $6 billion a year, and perhaps targeting that differently, not necessarily to low and middle income earners, but to smooth over the age and maybe targeted at older people at the same time. But it's a really complex issue, and it's something that at varying times, the government's reviewing it at the moment through a couple of small reviews that are outsourced to consultants. At varying times, the ALP, the opposition, has wanted to refer it to the Productivity Commission to have a look at. But inevitably what it comes down to is if the solution is not palatable to the majority of consumers, no politician is going to put it forward in a 3-year electoral cycle, because you do get that issue where people have sunk a lot of value into private health insurance, and they don't want to be suddenly disadvantaged because they've turned a certain age because of regulatory change or sovereign risk. So it's a tough one, but I think, in current trends, I mean, no other country in the world does community rating. It's a very fair system, and the funds do equalise the costs amongst themselves through a type of reinsurance system. But, we have to ensure that the entry point is sustainable. And we can do that in 2 ways: by reducing costs or by altering the regulations and the subsidy, and neither are easy.
Yeah. Yeah. And I think on the topic of, sort of making sure that we have products and I guess a framework for insurance that actually is fit for purpose in the current changing times that we're in. And, obviously these things don't change overnight, and it's sometimes quite hard to move, even what might be very, very good ideas. There was a comment made from again, one of the registrants talking about that. Is there any way that private health insurance cover can have the opportunity to opt into areas that the consumer would like to link to, instead of being locked into 3 very specific types of cover, but actually having it maybe a bit more customizable so that they only pay for these certain areas that they want? Is that something that, from a product perspective, something that insurers can actually build that allows it to be easy to understand and can be costed?
This is quite a controversial topic for me, because the current banding system of gold, silver, bronze, basic was introduced by the former health minister after some advice from competition experts who wanted to make the system easier for consumers to understand. But it was very complex to implement. It took years to categorise all the possible products and medical procedures into those bands, with a lot of concern from the different medical groups and patient representative groups that, were invited to comment. And then there's the inevitable unintended consequences of that, i.e. the system is very rigid. There's no, it can make it very difficult to offer affordable products at the top. and products of sufficient value at the bottom of, of that system. And so to manage the unintended consequences, I think it probably should be reviewed in line with some of the other reviews that are going on at the moment in health insurance about community rating and so forth. I wasn't super in favour of doing it this way. I really understood the need for consumers to be better able to navigate the complexity, but doing it in a way that's this rigid does have its problems. And I think we've seen in general insurance some of the issues that occurred when, for example, for top cover for general insurance, for things like floods and so forth in Northern Australia, you actually can't find a product that's, affordable, or you can't actually offer a product that's affordable. So the government's had to bail it out, and we really don't want to reach that situation with private health insurance. So I think I think it's too rigid, and I think it will need to be reviewed at some point.
Yeah. I think I'm just conscious of the fact that we're coming to the end of the time, but one thing I wanted to sneak in was something that Rachel, you mentioned a couple of times, and I think it's worth discussing because it's clearly an area of interest for a lot of people and broadly applicable to pretty much everyone. And it's this area of mental health. We did ask a question in the survey around, how since the beginning of the pandemic in early 2020, how people's mental health had changed or whether it gotten better or worse. And interestingly, 57% said that it was about the same, but 30% said that it was actually worse. And 2/3 of those people who said it was worse was actually, that it was COVID related in some way. I guess, maybe for anyone on the panel who wants to jump in, mental health is a topic of great interest to a lot of people. We are hearing that capacity and cost are two of the big impediments to access. What's the solution?
The solution, unfortunately, is a bigger workforce, more money and more resources, but it's got to be properly targeted, not in bureaucracy, as has tended to happen, but in a highly skilled workforce. But it's a very complex area, and with a few minutes to go, we can only touch the surface, but it is going to be a big challenge for the Australian society for the next probably 5-10 years.
I suppose we could also dream up, a future with vaccines that have positive mental health impact effects as well. I mean, technically, that's what we really want.
The poly pill. Yeah. Rachel?
Just a quick comment on what we've seen. We have seen an uptick in claims for inpatient mental health care as a result of the pandemic. It's all been in younger people, and a lot of it is due to factors that are perhaps occurring outside their actual health status. So these are people who have been confined to home with other people who are in an environment that's unsafe because they're in a domestic violence situation, or they've been confined to home with people that they're in conflict with, or they've been in a situation where they've been financially seriously disadvantaged. We've got people that are working multiple jobs out there. We've got more people working 4 or more, up to 4 jobs than we've ever have before. A lot of that was knocked out by COVID, or people had to change. And I think that as the job seeker payments have been reduced, people are under more stress, and that's causing some of the presentations. So, really what we need is some mechanism where people that have multiple issues aren't directed to an emergency department, which in fact is not the right place for them to go to have someone to look into all of these social issues, which will take some time. And, they don't require CPR, but they do require management through, this initial crisis. And until we get that right, and there's multiple areas, there are multiple areas of funding, then I think we're going to struggle. I think there are some great things that the government is funding at the moment, but, some new models of care, but they're quite early, trying to get some of this stuff right with team-based community care and so forth. They're quite new, but they'll take some time to develop. But I think what we've got to be careful of at the moment, while there's constraints in beds and so forth, is the investment in activities that drive demand. And some of the messages that I've seen in the media have not been helpful. All of our kids are going to suffer mental health problems as a result of the pandemic, this sort of thing, not helpful. It's
self-fulfilling.
Yeah, exactly. It's clearly not the case. And but we do need to have an appropriate landing spot for people that really are in strife.
Yeah. Well, look, thank you, Rachel. And we've unfortunately come to time on what's been a really, really fascinating conversation. What I'd like to do is, again, just remind people that this report is actually available at the australianhealthcareindex.com.au. The webinar will also be posted on there for those who missed certain parts of it or would like to go back or share it for other relevant stakeholders. The survey itself covers much more than what we talked about. These were the key insights, and does touch on GP care, dental care, and people's take on pharmacy and prescription medications. But the key takeaways from this particular edition, I think, for me, was certainly around the vaccine hesitancy and where we could actually do a little bit better in perhaps educating people on the safety of vaccines, and the rethinking, perhaps, given that we are living in a slightly new world, on how we might be able to fund healthcare in general and make it more accessible to patients, is certainly a fascinating conversation, and something I think hopefully those people in the policy side of things who might be listening would be coming to the table to have a rethink of how we might be able to look at of new ways of funding, innovative ways of funding care and access. But look, again, thank you very much to our panelists, to Stephen, to Rachel, and to Seth, for your time and for your contributions. And for those of you who joined, we hope to see you at our next webinar. Thank you very much.